Hi everyone, I'm Angela Meggiolaro, ATN Fellow based in Hamburg Center for Health Economics. My PhD topic is number 10 on comparing quality of care across healthcare systems. So the main objective of this project was to build an aggregate quality index in order to compare hospital performance in myocardial infarction treatment within and between countries. As outcomes, we considered both mortality and readmission following myocardial infarction and myocardial infarction interventions. For the econometrics strategy, we recall that health outcomes is a function of patient, hospital, and regional level determinants, and we applied a two-stage simultaneous accelerated failure time regression model, and we also computed variance-based weight. This tool is reliable for policy makers, either for monitoring hospital performance in imperfect healthcare markets and to foster hospital quality in competitive markets. In this project, we distinguished two phases. In the first part, we tried to validate the index within German hospitals, and in the second stage, we extended the methodology to the Italian sample. In the first phase, we used administrative data from a BAM insurance database, and we consider a period of time spanning from 2005 to 2017. We also completed the patient level information with the INCR free databases for the German sample. We included 4 cardiovascular events, 2 interventions, bypass and pacemaker implantation, and 2 myocardial infarction classified according to the ICD-10 codes with ST elevation and non-ST elevation. We accounted also for competent risk of death and readmission, and we also took into account the severity of patient condition at readmission by dividing the days to readmission for the total in hospital stays. In the graph below, you can see that we consider days to time to mortality as the time as the time lapse between the first admission and death, and the time to readmission as a time lapse between the discharge and the next readmission. The extended model consider as a dependent variable the logarithm of time to event. In the covariates, we consider for cardiovascular events, which one specific for the outcomes, and the patient level we control for comorbidities. We use the LXL index for the cardiovascular interventions, and the Ontario myocardial infarction score for the STEMI and non-STEMI myocardial infarction. Then we also controlled for distance from the hospital, the general patient characteristics, and pharmacotherapy. At hospital level, we controlled for ownership, volume beds, ownership interacted with beds, hospital staff, and to observe some spillover effect between the East and West Germany. After the reunification, we also controlled for hospital geolocation. And finally, we also plugged the hospital dummies specific for outcome and intervention events. At regional level, we also considered the GDP per capita. So from the first step, AFT regression, we obtained the variance-covariance matrix. This is not an identity matrix, since the system of simultaneous regressions allows for correlation across the elements. And then we computed the standardized residuals, and we derived weights from the inverse of this formula. So from the first step AFT regression, we obtained weights, and that we use in the second step AFT regression. The archaic criterion shows the best fit for the log normal distribution. From the second step AFT regression, we estimated the hospital parameter. Please notice that in the second step we replaced the hospital dummies specific for outcome and interventions in the first step with the hospital dummies themselves that we consider fixed effect. Then the hospital estimates and the corresponding confidence interval were standardized into a scale between 0 and 10, and we computed the quality index. So from 2005 to 2017 we ranked 452 hospitals, 11 people died, and 157,000 people were readmitted. The weights, so mortality showed the higher value for the all cardiovascular events with respect to readmission. In other words, we are able to estimate with more precision mortality, and also to give these events more weight in their overall classification, in the overall rank. So on the right side you can see the hospital plots, in red the poor performers, and in green the highest performers. Overall teaching hospital performed better than non-teaching hospital. The mean rank was 4.35. Public hospital apparently are the worst performers, and private not-for-profit are the best hospital performers in Germany. In the second stage of this project, we tried to compare German and Italian data, and we restricted the analysis to 7 years, from 2010 to 2017, and we considered only readmission for cardiovascular events. We obtained administrative data from the Italian Ministry of Health, and as you can see on the right, these are the hospital ranking at the top for Germany and at the bottom for Italy. Overall, Germany tends to perform better than Italy. In Italy, we don't observe outliers in performance. Again, private not-for-profit hospital perform better in Germany, and it's not possible to establish the ownership role for Italy, because the 84% of the hospitals are public. But we can conclude that some variation can be explained by different hospitals market structure. So overall, this index specified an indirect measures of hospital performance, since we wiped out all the amounts of variance that we attributed to outcome and intervention to build weights. The system of simultaneous AFT regression is more efficient compared to generalized linear model that rely on dichotomized data. Variance weight elicitation is data driven and robust to normative, more robust than normative approaches, and the risk adjustment and the acute clinical events prevents selection bias and cherry picking. The methodology is robust, and again we show that administrative in and outpatient data enables to follow up patients across all the healthcare sectors, and also to observe rare events such as mortality. In conclusion, this is a viable method that aggregates several dimensions of quality of care. Quality index can trigger quality-based competition in competitive healthcare hospitals markets, and can be used also for monitoring purposes in imperfect healthcare market. The statistical tool is based on precision, so it can also address patients' or hospitals' choice. For further research, we clearly recommend mortality as a valid outcome for cardiovascular diseases outcomes, but sometimes this is not the main objective of care. Think about palliative care. And also additional data from other healthcare insurances or countries will increase the discriminatory power of the index and can help to clarify the role of hospital ownership in influencing quality of care. Thank you for your attention.